MedCram.com.
I finally get a chance to take someone with moderate to severe COVID-19 out of the hospital and into the sunlight to see what happens next. This is Dr. Roger Schwelt, and welcome to another MedCram COVID-19 update. And I'm really excited about this because I finally got a chance to put it all on the line. For those of you who don't know who I am, I'm Dr. Roger Schwelt. I'm a pulmonary and critical care specialist, and we've been doing MedCram updates since 2020 on the pandemic, but we also do continuing medical education. We also do lectures on medical topics, things like ABGs, EKGs, congestive heart failure, the interpretation of labs, all sorts of things for healthcare providers. This video we are doing on the effect of sunlight, not just on theoretical COVID-19, but also what actually happens to real patients. So this all started when COVID-19 was hitting the United States, specifically Southern California, and I had to gear up and figure out what I was going to do. And then we're going to talk about what happened during the pandemic. I was really looking for answers about how I could save my patients. And we did a lot of videos, you may recall from that time. We did a video on vitamin D, and that was published on December 10th, 2020. Although we talked about vitamin D a number of times, even going back to as far as March of 2020. As you may remember, there was a lot of data at the time that people who have high levels of vitamin D typically do better than those that had low levels of vitamin D. And there was a lot of debate and argumentation about whether or not supplementation with vitamin D actually improved outcomes. There was some data that seemed to indicate that, and there was some data that didn't seem to indicate that. It seems as though there was a lead time bias, or to put it more correctly, there was differences in the types of vitamin D substrates. And for instance, calcifediol, which is something very quickly acting, seemed to have more success in terms of repleting vitamin D. It took me about a year of research and looking into this aspect, and I finally realized that vitamin D is not a substitute for getting out into the sun. And so we published in January of 2022 one of our most groundbreaking videos, I think, of all of the entire set, which is Light as Medicine, where we said that vitamin D is not enough. In that video, we talked about the effects of near-infrared radiation on the mitochondria, the effect of near-infrared radiation on nitric oxide stimulation, and also discussed near-infrared radiation on the oxidative balance of our cells. We discussed findings of Scott Zimmerman and Russell Reiter and a number of other authors on this topic, and also published just a few days later a case for sunlight in COVID, where we went over the evidence. And for anyone who doesn't know that evidence, I highly recommend looking over that data and reviewing the scientific research that we went through very specifically in looking at the effects of near-infrared radiation in COVID-19. Later in 2022, we looked at some data that showed that near-infrared light relieved the same type of hyperinflammation mechanism that we saw in COVID-19. This is a toll-like receptor 4-dependent hyperinflammation that we saw, and near-infrared light actually ameliorated that, giving us hope that sunlight therapy would actually be very good for patients with COVID-19. And we actually came out with a video titled Infrared Light Neutralizes Spike Toxicity, and we published that in August of 2022. The final nail in the coffin that convinced me that sunlight would be an adequate and productive intervention for COVID-19 was this paper that was published in one of the top journals. Impact factor was 6.252, top 5% of journals, the Journal of Photochemistry and Photobiology, as you can see there. And this was a high level of evidence randomized controlled trial, which looked at specifically giving patients in the hospital with mild to moderate COVID, not intubated, not in the ICU, near infrared radiation daily using a jacket, and the outcomes in that were tremendous. There was a priori standards in terms of pulmonary function test, hematological evaluation, and it showed statistical differences in these patients. In fact, these patients actually were discharged 4 days earlier from the hospital because they recovered. And this was actually published in December of 2022. We saw that data, and we published our video in January of 2023. A lot of this review of the data, for me, what convinced me that sunlight was such a good intervention in patients with COVID-19 was this data that sort of emerged over the last year or so. Put that together with the fact that we really have not seen hospitalizations from COVID-19 in the last year or two. We saw a lot of hospitalizations in 2020 and in most of 2021. But by the time 2021 started to come to the end, certainly people were still getting infected. Certainly people were still getting sick. There were still a lot of issues to be dealt with in terms of long COVID that I was seeing a lot of in the clinic. But in terms of severe COVID patients being admitted to the hospital, either on the floor or especially in the intensive care unit, these things had really by this point dropped off. And realized that as a critical care specialist, I'm not going to be called on patients with COVID-19 unless these patients look like they need to be going to the intensive care unit. You can imagine my surprise when, just in the last month, I was asked to see a patient on the floor at our hospital who had severe COVID-19 and was looking as though he was needing to be intubated at some point, and so they were getting me involved. Let me go over that case with you, and I've gotten permission from the patient and the patient's family to go over this. This is what happened. The patient was initially hospitalized at a different hospital for an unrelated orthopedic issue. And during that hospitalization, we'll call that day one, the patient came down with symptoms and was tested and actually developed a SARS-CoV-2 positivity and COVID-19 positive symptoms in the hospital. He was actually given dexamethasone at that time, but he did not tolerate it. He had some adverse reactions to it. And the patient continued to linger along and was finally discharged by day 7 after his COVID-19 infection, went home and was actually stable enough to go home. So he wasn't having a lot of symptoms. Just 4 days later, on day 11, the patient came back to our hospital. So this is a different hospitalization. And he came in with 2 to 3 day history of shortness of breath and chest pain and cough. History and physical was done by the hospitalist at that time. The patient was placed on 4 liters of nasal cannula. And this is what a nasal cannula looks like down here. You can see it's basically a delivery device. It's sort of the lowest level of oxygen that you can give somebody. And again, as I mentioned, the patient was placed on 4 liters of oxygen. He was also at that time restarted back on steroids, which he had been on before, but had not responded as well to them. He was also started on azithromycin and was started on Tylenol initially, but the hospitalist had called me at that time and I spoke with him over the phone and recommended that perhaps de-seeing the Tylenol might not be a bad idea because we like to have fevers help in terms of starting up the immune system. But I was not consulted formally on this patient, and the patient was admitted to the floor and was started on all these medications, as I mentioned. The next day, unfortunately, the patient's oxygen requirement went up to 10 liters of oxymizer. Now, when the oxygen requirement goes up that high, you actually need to have a reservoir of oxygen, and that's known as an oxymizer. That's why this sort of mustache-looking type device is put on, and that's so that there can be a reservoir of oxygen so that when the patient breathes in, they can get more oxygen. And unfortunately, he went up to 10 liters on day 12, and I'm calling this day 12, but it was really day number 2 for our hospitalization, but it's day 12 going back to the first day of COVID. The next day after that, he was still on 10 liters of oxymizer and no real improvement. The next day, this would be day number 1, 2, 3, 4, since the day he came in. This sort of came in late on day 11. The patient's oxygen requirement went up significantly, up to 35 liters, 100% high flow. And that's one of these things. These high flow devices are actually hooked up to machines that use tremendous amounts of oxygen. This is something that many people don't realize during the pandemic. When you are on high flow oxygen, which is what we try to do to keep people off the ventilator, this is using a tremendous amount of volume of pure oxygen continuously. And this was happening on multiple patients. And so you can imagine that the oxygen trucks were really trying to make a lot of deliveries to get that oxygen to the hospitals. And this is something that some hospitals were actually in danger of running out of during the pandemic. But nevertheless, because the patient in this case went up to 35 liters of oxygen and required 100% oxygen, this was a departure from where we were the day before. And it was at this point right here that I, as the attending intensivist in the ICU, was asked to see this patient to see what was going on. And so I saw this patient, and imagine all the things that I've talked to you about, all of the studies that we've gone over, all of those things, the theoretics, the randomized controlled trials, all of those studies. And I'm seeing this patient now for the first time, and this is the type of patient I have not seen in a very long time, probably in more than a year, at least in our hospital. These severe COVID patients. And I can tell you that his chest x-ray had bilateral infiltrates on both sides, very clearly looking like COVID-19. He had the biomarker hallmarks of it with an elevated D-dimer. He had elevated CRP. His lymphocytes were low. This is the classic patient I did take a history. The patient had been vaccinated twice and was also boosted. So this goes to show you that even vaccination is not 100%. There's no intervention that is 100%. We have to keep that in mind. Even what I'm about to talk to you about today, which is going out into the sunlight, is not 100% effective. There is nothing that is 100% effective. We have to realize that in medicine, that not every tool in our tool chest is going to work every single time. Nevertheless, I walked into this gentleman's room. I had to put on an N95 mask, of course. I put on a sterilization gown. I had not done this in a long time. It was actually kind of odd. And I walked into this isolation room. He was with his daughter, and the room was dark. There was no light coming into this room. The window was there, but the blind was pulled down, and I could just tell the depression in this room. The patient was asking me questions after I got into talking with him. How long did he have? I had an epiphany at that time, basically what he needed to do. I decided at that point that he needed to go out into full sun. I didn't know how that was going to happen, but I knew that if we were going to do anything with this gentleman, that he needed to get out into the sunshine. And so after talking to him and making some comments to not only the patient, but his daughter, I came out, talked to the patient's nurse, talked to the patient's respiratory therapist, talked to the charge nurse, got them together, and we had a huddle and basically said, I don't care what it takes. I know this guy is on a lot of oxygen, and we need to figure out some way of getting this guy outside. And it was a bright, sunny day that day. This is in Southern California, of course, in late autumn. We put our heads together, and our respiratory therapist was able to get a couple of oxygen tanks put together. We were able to get him into a wheelchair, and we were able to put a mask on him as we went through the unit until we got outside. We were able to get this guy outside into the sunlight. So let me show you what that looked like. This is a photo that I took on that very first day that we got him out. Specifically, I've asked permission from the patient and his daughter to publish this here on our video. You can see our respiratory therapist and our charge nurse there. We've got this gentleman outside in our atrium. It's actually a wonderful atrium. We get a little bit of wind where we are, but because there's 4 walls to this little atrium and we can go out there and there's nice plants and flowers and trees, it's actually protected from the elements, but you get a lot of good sun. That was exactly the point. And you can see that he's getting direct sunlight, and that infrared is going to penetrate right through those clothes, that hospital gown. Let's take a look and see what happened. He did that for about 20 minutes, and the next day I came in very eager to find out how things had gone. Because typically in these situations, when I remember taking care of COVID patients, when they were on 35 liters at 100%, this would go on for days. And generally speaking, they seem to improve when we put them on steroids. But notice in this case, we started steroids back here, and the patient had not improved. In fact, the patient had gotten worse despite starting antibiotics and Solumedrol. We started the sunlight right here on day number 14. The next day, he was back down to 15 liters oximizer. And from that point onward, there was a steady decline in the oxygen requirement. He went to 10 liters oximizer the next day, then 6, then 4, and then finally off the oxygen and was able to be discharged to an acute rehab where he could continue his orthopedic recovery. So a couple of things. This is anecdotal. So this is not a research study. I cannot make any causative proofs of anything about this case. But what it was for me was a proof of concept, all of the theory that we had reviewed, everything coming together in a patient, an actual physical human being that was in front of me. And I have to say, it was gratifying to see when we got the patient out there that it was possible to get somebody so sick and requiring so much oxygen outside into the sun. So if nothing else, what this did prove is that it is possible to get sick patients that are not on ventilators outside if we really want to do that. Is it possible that the Solumedrol could have taken 2 or 3 days to kick in? Yeah, it's possible. That's certainly a possibility, and that all of this is related to the Solumedrol that was started. I personally have never seen somebody with COVID coming in on Solumedrol or other steroids or even dexamethasone improve this dramatically, this quickly. And when we stopped the Solumedrol, a number of times we saw a rebound where the patient got worse. That did not happen in this case. I've actually followed up with the patient and his daughter, and the patient, from a respiratory standpoint, is still not requiring oxygen, or sometimes maybe 1 or 2 liters because of heart issues, not because of COVID-19. So lest you think that this is some sort of a new discovery, that this is somehow a new thing that nobody has ever thought about before. Let me disabuse you of that notion. If anything, this is a rediscovery of something that we in the medical field seem to know very well 100 years ago. There are multiple examples where this was done on a routine basis, usually before the discovery of antibiotics prior to 1928, when they had little other options, but they found that this was actually very effective. Tuberculosis sanitariums, for instance, use this all the time. We've talked about multiple times in the pandemic of 1918 that part of the rational therapy of the Northeast sanitariums was not only sunshine, but also the use of hydrotherapy. In this situation, early on in the pandemic, one of the things that was very essential in preventing pneumonia, which was 50% of the time deadly, was the use of sunshine, rest, hydrotherapy, and sleep. And you can see here that there was a dramatic reduction in the amount of pneumonia in those types of patients. So I started to think if other people had thought about this, perhaps where the infrastructure is maybe not as good, or maybe where it is good. And I came up with this paper. This was published early in 2020, where they looked at sunlight in Indonesia. This was a study in the central pandemic area of Indonesia, and they found that sunlight correlated significantly to COVID-19 patients' recovery in Jakarta, Indonesia. So why is this? Is sunlight just good for COVID-19? This is the top killers by week in the United States. Right here on each of these lines is December to January, and it's also a mark of when the sun is at the lowest and we get the least amount of sunlight. And I want you to notice something. Let's take a look here, heart disease. Notice that every year, heart disease deaths peak right at the same time that we get the least amount of sunlight. Isn't that interesting? What about cancer? Notice it's the same as well. Although it doesn't seem to undulate as much, there is still an undulation, again, with peak cancer deaths at the same time when the sun is the lowest in the sky and we're getting the least amount of light. What about strokes? Notice here strokes, if we follow this line down in blue and we look at chronic lower respiratory disease and we look at Alzheimer's disease and diabetes and influenza, notice that all of these are peaking just after we are getting the least amount of sunlight. This is not by accident. This is much, much more than just vitamin D. Let's take a look here again. This is the influenza deaths per week in the United States. They're all peaking just after the new year, right after we get the least amount of sunlight on December 21st. Every single year we can predict that this is exactly what's going to happen. But you might say, well, maybe it's temperature, maybe it's humidity. Let's take a look at that. This was a study that was done on COVID-19 specifically, looking at latitudes versus temperature versus humidity. And notice what they showed here. In the autumn of 2020, they asked this question: when the surge hit Europe in the autumn, which countries did the surge come on first? And they said, well, let's rank them by temperature. In other words, let's look at the temperatures throughout Europe and see which ones were the coldest and which ones were the hottest as we went from the dates from September 9 to October 19. And let's see what happens in terms of the temperature going across and see if there's any kind of relatedness to it. And in fact, they found absolutely no relatedness. The R2 was 0.00. They did the same thing with humidity. Again, absolutely no correlation whatsoever in terms of the surge of COVID-19 in Europe in 2020. So it doesn't seem as though temperature or humidity has anything to do with the susceptibility to human beings to that surge of COVID-19, at least in 2020, when there was no vaccination, there was no other things that we were doing at that point. However, what was very highly correlated, R of 0.77, was latitude. In other words, it started in the highest points on the Earth, which was Finland, and it ended in Greece. It seems as though sunlight has an effect on the human body, not just for the flu, not just for all those diseases that we just showed you, but also for COVID-19. But you might say, well, maybe it's vitamin D. Maybe all of this is vitamin D, and again, we just need to be taking more levels of vitamin D. I would suggest to you that vitamin D is a marker. Here in this study, they actually looked at UVA, which is a marker for the amount of sunlight that is coming through. And what they did was they eliminated all of the areas in the United States where you could get enough vitamin D during the winter In other words, the areas that they're looking at here, both in the United States, in England, and in Italy, these areas were not getting any vitamin D. We're not getting enough ultraviolet B light to give them any vitamin D. And so what did they find? When they looked at the number of COVID-19 deaths per million, they found that the number of deaths per million went down when the amount of UVA went up. So in other words, the lower in latitude you were, the lower the amount of COVID-19 deaths per million. They found that not just in the United States, they also found that in England and Italy, and that was after they corrected for population density, case proportion, age, ethnicity, and comorbidities. In fact, it was so stark that the authors actually said, in conclusion, this study is observational, and therefore any causal interpretation needs to be taken with caution. However, if the relationship identified proves to be causal, it suggests that optimizing sun exposure may be a public health intervention. Given that the effect appears independent of a vitamin D pathway, it suggests possible new COVID-19 therapies. So I set out to look at these possible therapies, this latitude on a much bigger scale globally. And I teamed up with Margaret Skutch, who is associated with geography in the University of Mexico. And we did a study looking at globally the BMI, the amount of light, of course, using latitude, and COVID-19 mortality. There are different clusters. Cluster 1 shows high percent BMI. In other words, there's a high percentage of people with high BMIs in the country, and they have high deaths. So the United States was one of those. That's cluster 1. That's these very light-colored countries. But what I want to draw your attention to is cluster 3 and cluster 4. So in cluster 3 and 4, they are both high BMI, large proportion of people who are overweight. But notice that in cluster 3, which is the orange, there was low deaths, but in cluster 4, which is the dark orange, there was medium deaths. All of these countries here have high BMI, but they had low deaths. Now notice that as you push more towards the north, you now move into the high BMIs, which have high deaths. And what's going on there almost universally? There is a higher latitude. They are getting less light. And that was actually statistically significant. One of the things that is very well shown is that infrared light, as we talked about before, actually relieves hyperinflammation of the type that we know is induced by COVID-19. And with that, we also know that in a randomized controlled trial, it showed that photobiomodulation in the near infrared spectrum actually improved significantly outcomes in COVID-19. This actually shows causation because this is a randomized controlled trial. But there was a number of scientists that met in 2019 looking at insufficient sun exposure has become a real public health problem. And what they have said is exactly what we are saying now. So there are people that are realizing this, many other people that have looked at this even before we did here at MedCram and saw that this was a real problem. One of the things that I was able to find is this Sunshine Health Foundation, which is interested in people understanding that they need to get outside into the sun. And they say here that recent advances in medical science have revealed that to achieve good health and a long life, it is not enough that you eat a healthy diet, exercise regularly, and see a doctor often. You also need to get enough sun exposure to maintain your serum vitamin D levels at 30 nanograms per milliliter or higher. But they also say, by the way, in this website that vitamin D supplements are not a substitute for sun exposure for the simple reason that they do not provide any of these biomolecules other than vitamin D. And they talk about the biomolecules that we have talked about. And we have talked also about near infrared light and also melatonin in the mitochondria. I highly recommend going to their website called sunshinehealthfoundation.org and specifically go to the history page where you can learn about all of the discoveries literally in the last 10 to 20 years that has given us insight about how important it is to have sun exposure. This article, Let There Be Light, the Healing Power of Sunlight in Hospital Settings, shows that in the hospital itself, if you're exposed to sunlight, there is an improvement in terms of discharge. In some cases, there's even improvement in terms of survival after surgery. So for me and my patients at my hospital, this atrium is going to be part of my treatment plan for many patients. I think this is a huge public health issue, and I think it's one that needs to be raised. And so I am encouraging each one of you that's watching this to get involved and to send this to as many people as possible, because I believe that there's a huge amount of people that are not getting better because of lack of understanding about this issue. So this is what I would like you to do. For those of you in healthcare, be a champion at your hospital for sunlight. If you understand the science and learn the science, you can also talk to people about this and advocate for your patients to get outside. Make sure you're practicing what you preach. Whenever I have lunch at the hospital, I'm always outside making sure that I'm getting plenty of sunlight. Make sure you educate your colleagues. This is something that can sound very fringy. It can sound like it's not real. There is good, solid scientific evidence that getting out into the sun is extremely beneficial, especially for patients who are acutely ill. Move the cause. Make sure that people are understanding this. People who know who I am and know me at the hospital know that I'm all about getting outside into the sunshine, and then I practice what I preach. Use your clout. If you are a hospital administrator, let me tell you about insurance. This should be music to their ears, because when people get outside, understand the monetary gain that insurance companies and hospitals have. Today, many of the arrangements that medical insurers have with hospitals is on a capitated environment, or something called a DRG. This means that a hospital is paid based on the diagnosis of the patient, and the doctor is the one that makes the diagnosis of the patient. Therefore, if the hospital is going to get a specific sum of money based on a diagnosis, then it's imperative that they do whatever they can to find out any way they can to get that patient better and out of their hospital, so they can make more room for other patients that need to come in, and specifically spend less money on keeping that patient around longer and not getting better. So in other words, everybody's incentivized to not have the patient remain sick, but to get healthy. And if it shows that sunlight and sunshine and light exposure is going to speed that up and get patients out more quickly, this is something that I believe hospitals will be very interested in, not only just hospitals, but also health plans and medical insurance plans. If their patients are understanding that they can be better, healthier, and prevent a lot of diseases by getting outside into the sunlight, then this is the sort of thing that if they put this into practice, we'll see immediate benefits. So that's for healthcare providers. I will say here that for patients and families, be a champion in your family. Learn the science, explain it to them, show them that this is what they need to do. Learn that science about sunlight for your family, but also you need to practice what you preach, educate your family. And if you or your loved one have the unfortunate experience to have to be hospitalized, gently, and I put this word here, gently, educate the doctors and the nurses taking care of you, the respiratory therapist in the hospital. When you ask them to get you outside, realize that they are busy, they have a lot of things to do, but gently press them, educate them to say that you would really love to get outside for 20 to 30 minutes. Sometimes you may be in an environment where it's very cold outside and may not be able to do that. Use your own judgment in that area, but do the best that you can do. If you need to open up windows to allow that light to come in during the day. And if it is possible to get outside, then I would highly recommend that you do that. You can request it for family members that are in the hospital as well. This is really a turning point for me in terms of my medical care. I'm going to do everything that I can to get patients out. And what I have learned in this experience is that even patients that are on 35 liters of high flow, 100% oxygen, if there is a will to do so, when I talked to this patient a few weeks after this happened, and we reflected back on that moment, he really didn't feel like he wanted to go outside. He was depressed. He didn't want to be moved. But he told me, unsolicited, he told me, you know, Doc, when I went out into that sun felt so good. I can tell you those oxygen requirements came right down from that day, and they never went back up again. I just think about the possibilities if we could do this for people when they come into the hospital and they are sick. If you thought that this was helpful, please subscribe to us, turn on your notifications, give us a thumbs up. If you're a healthcare provider looking into this, choose us for your continuing medical education at medcram.com. We would love to be your continuing medical education provider. Realize also, those of you who are not in general medicine, but maybe nurses or PAs, that we also offer continuing education credits as well. Join us at medcram.com. Thanks for joining us.